most interested in, really. It's kind of the management of psychotropic medications in order to make psychedelic experiences safe and effective. And then, of course, once you've kind of accessed the non-ordinary or neuroplastic state of the psychedelic, what are you going to do with that? Maybe a nice analogy to kind of finish would be like, well, psychedelics can point the direction, but it's still going to be up to the person and their therapeutic team to help them walk the path. That's all I got as far as slides. I'm going to stop sharing and open us up for question and answer here.
Thank you so much. That was awesome. And we have so many questions. We are very happy to have you here. Like I said, we even have carryover questions from other previous talks. So this is really, everybody's questions are related to pharmacology. I guess I'll kind of start where you started, talking about neuroplasticity. We have a few questions on that. Somebody is asking if neuroplasticity and use of psychedelics could help with recovering from brain damage. Similarly, somebody mentioned about how traumatic brain injury is often an exclusion criteria for psychedelics, even in the case of, like, say, PTSD. Somebody has PTSD from a traumatic brain injury. What are your thoughts on neuroplasticity and traumatic brain injuries?
Yeah.
Alex?
Yeah. So the thing with brain injuries is that it probably depends on what part of the brain was hit and how hard it was hit. So the most common types of traumatic brain injuries are going to be frontal lobe injuries, because people get punched when they have motor vehicle accidents. They're going to hit the kind of front of their face. And this is where that prefrontal cortex is. So it seems that psychedelics can create neuroplasticity in that brain region. And there's oftentimes when people have a traumatic brain injury, they experience things like PTSD, depression, maybe perhaps just like anger, irritability, like personality changes, or some of the things that happen afterwards. At least hypothetically, psychedelics may be amenable to helping that type of population. I mentioned that they get excluded from trials of major depressive disorder or PTSD for the moment, because they're afraid that those neurological types of conditions are going to confound their results somehow. So they're really trying to create a trial with pure major depression or pure PTSD, which is obviously not really how the real world functions. This isn't just a criticism of psychedelic trials. This is just like all types of studies in medicine, is you pick a specific population to study them in, whereas I mentioned there's also trials now that are looking specifically at things like traumatic brain injuries. So, trials that actually select for those. And I really hope it works, because traumatic brain injuries are something that do not respond very well to many of the traditional types of psychiatric medications or psychotropics at all. And, DMT, I see like clinical trials for like stroke recovery too. And, this is another therapeutic area that, if you can't catch the stroke early enough and use kind of one of the clot busting types of drugs, then, functional recovery can be extremely difficult and tends to be kind of irreversible in a lot of cases. But again, where did the stroke occur in the brain? How massive was the stroke? What is the level of functional impairment there? My kind of suspicion is that psychedelics will probably work for some type of neurological injuries in some regions of the brain, but to kind of globally think, well, they just cause all sorts of neuronal growth. It can repair any region of the brain and any severity of injury. I'm skeptical.
Yeah, good point, too, about the clinical trials. I mean, unfortunately, with exclusion and stuff like that, it can be really frustrating now, but it's definitely a process, and you've got to start somewhere. Continuing on with neuroplasticity, I'm not sure if LSD is much different or if it's similar. Somebody asked specifically about LSD.
Yeah, so actually a lot of the sort of, at least neuroimaging that they have on the default mode network is done with LSD. So LSD definitely has the kind of synaptic plasticity of the other psychedelics. I kind of think that, when people kind of think of psychedelics in a bad rap, LSD is kind of the poster child. Acid even creates this kind of like corrosive sort of like connotation to it. And then it's also a longer experience. It's an 8 to 12 hour type of experience, where psilocybin and MDMA is more like 4 to 6. So perhaps, LSD is just a little too long for the clinic, or many therapists, that, like we could get the same amount of work done in 4 to 6 hours. So, maybe it's just not like a front runner as far as clinical research right now, at least in like patient populations. But as far as like neuroimaging and as a probe to understanding what psychedelics do, LSD is used quite often.
Moving on to microdosing, because of course, perfect question for psychopharmacologists talking about psychedelics. Can you talk about psilocybin and microdosing, and how that compares to like a one-time large dose?
Yeah, so microdosing is essentially a practice of using very small doses of psychedelics on a semi-chronic or consistent type of basis. So they think of microdoses about 5 to 10% of what you would consider a full dose. And instead of using it very intermittently with this model of, supervised accompanied support, microdosing is often used maybe 3 times a week on alternating days, or, some microdosing regimens will say things like, 4 or 5 days on and then a couple of days off. And there's lots of surveys out there where people are saying, yes, microdosing is wonderful. So far, the controlled research has not been very impressive at all. And, some of the most methodologically rigorous studies have suggested that microdosing is probably a placebo type of effect. So the jury really is out in my mind as far as the efficacy of microdosing, whereas the macrodosing with therapeutic support is literally producing unprecedented results as far as what we've seen in psychiatry. Now, I'll add that, psilocybin binds serotonin 2A receptors. It binds other serotonin receptor subtypes, including the serotonin 2B receptor, which is a receptor that has been linked with chronic drug toxicities like valvular heart disease. There's been several drugs that have been pulled from the market over the years because they bind with serotonin 2B receptors and they can cause heart valve thickening. So beyond the jury being out on the efficacy of microdosing, I think the jury is also out as far as the chronic safety, or so what does it mean to ingest small amounts of psychedelics on an almost everyday basis. That's something that we don't have much good research about, and some pause for concern or precedent from other substances.
Sort of along the same path of like that sub-psychoactive dose, it makes me think, in terms of mystical experiences mediating some of the beneficial outcomes. Somebody asked, can you discuss why the human brain is structured to have a mystical and a dissociative, type of experience? And, what do you think about sort of like this mediating element of the mystical experience to these outcomes?
Yeah. Wow. The first part of the question is literally one of the most fascinating questions that there is, really, in my mind, or it's kind of like, why is it that if we just tap on this serotonin 2A receptor and put you in a safe and supporting environment where perhaps there's a little bit of intention and ritual employed throughout it, then there's a really good chance that you're going to have a bona fide mystical or religious type of experience. And, I think, to me, it suggests that, well, maybe humans have co-evolved with psychedelics for a long time, or perhaps it just means that there are elements of how we are created that means that, spirituality is part of it. And, the idea of spirit and science, oil and water, they just don't mix so well. And, this is essentially why I call our website Spirit Farms is because there is underlying biological types of mechanisms that involve spirituality and spiritual experience. And there's plenty of surveys out there that many people, 25% of people have some type of spontaneous mystical experience throughout their life. Particularly near-death experiences can elicit these types of effects. Different religious practices and traditions like prolonged fasting, is also, notorious for kind of creating, these types of states. And, do I think the mystical experience is the mystical bullet? And, that is what is driving absolutely all benefits? No, not really. I mean, look at Abigail's story, right? It was kind of like, well, maybe there are some spiritual effects of these substances, but it was really encountering all of my traumas and feeling into all of the different areas of my life and facing all of those things that allowed me to do the integration work and get to the place I am now. And so I personally think the trajectory of a psilocybin experience is before you meet God, you meet yourself. And, if you've got a closet full of skeletons for the last 20 or 30 years, those first few hours of the experience could very well be quite intense and quite challenging emotionally, psychologically, physically, right? But usually at some point in that experience, given they're in a safe and supportive setting, the clouds part, and there are some different, very spiritual types of effects that happen too.
A very interesting question indeed. So I will be very curious to see what the science continues to uncover on that one. Can you comment on the rate of psychosis? And then somebody also asked about hallucinogen, persisting perceptual disorder, and things like that. I know that they're somewhat rare, but definitely concerning. So thoughts on that?
Yeah, so it's really difficult to comment on the rate, right? Because this is not something that is very well measured out there. And I think a lot of the times when a psychedelic does precipitate a type of psychosis or perhaps mania, it usually is in an individual that has either had those things before or is potentially predisposed to them. So thinking about onset age ranges of things like schizophrenia or bipolar disorder, they're usually teens through perhaps early 30s, right? So perhaps these candidates, need some additional screening or counseling around these things. Things like ayahuasca, have like observational studies, and they'll show that, well, people in their late teens and early 20s that drink ayahuasca do not have, recurrences of schizophrenia that are higher than the general type of population. So this is an area that I personally would like to see a lot more research into, because it's a really common question. It's like, okay, I have a bipolar condition. Does that mean I can never, ever use a serotonergic psychedelic? And it's kind of like, well, they're considered contraindicated because they could precipitate those types of states, but so can SSRI monotherapy, and so can cocaine, and so can withdrawal from alcohol, and so can triple espressos at 9 p.m. when you're under a lot of stress during finals week. So I think the jury is kind of like out as far as like, okay, we know that there is this risk, and we know that it is a rare type of risk overall, but how does it stack up against other types of substances or circumstances that we know also have these kinds of risks to them? And what are the real factors, right? Is it a very high dose in an uncontrolled setting has a much higher risk of that occurring than someone that's prepared adequately for what they may encounter, or the dose is moderate and the environment is controlled? I think that these factors probably make pretty big differences in the safety of the experiences overall, and maybe what some of the post-use effects are as well. And I'll say really similar things about HPPD as far as that we only have observational research that says it's rare. And yeah.
You got me with the triple espressos at 9 p.m. on finals week. But yeah, no, it's so true. I mean, even being a nurse and working inpatient, things like steroids can trip people into
Right. Yeah, you see adverse psychological reactions to all sorts of things out there. So it really does beg the question is like, well, what is the risk of these things versus others? And there's, to my reading, it's pretty extensive. I can't find the answer.
The risk versus the benefits even.
Yeah.
In terms of like anti-inflammatory properties of psychedelics, are there any indications for any kind of autoimmune disorders? Anything like that on the horizon?
I haven't seen any clinical trials planned that address psychedelic assisted therapy for a specific type of autoimmune condition. There are some review articles out there that talk about the anti-inflammatory properties of psychedelics in the context of autoimmunity and how that could, it's like a postulated type of thing rather than well known. There are different anecdotes. There's a book out there by Dr. Joseph Tafur called Fellowship of the River, where he talks about people that have things like inflammatory bowel syndrome or Crohn's disease that go down to the Amazon and they get put on a pretty strict type of jungle diet and use ayahuasca over a period of months. And a lot of their symptoms tend to kind of clear up. And a lot of autoimmune conditions are highly, highly associated with psychiatric conditions as well. So it is something that, well, maybe there is some type of psychosomatic component to some people's autoimmune types of illnesses, or, perhaps in some ways it is all the immune system. That the immune system, to me, its most basic function is to tell self from non-self. It's supposed to recognize viruses, fungus, cancer cells even, right, and kind of get rid of them. And autoimmunity is the body attacking itself. Whereas, I think of, what is the sort of ego structure of my brain? Like, what's its function? Well, it tells self from non-self. It tells Ben from the rest of the world. So if psychedelics can somehow change this relationship of self and non-self, maybe. But that's very, I think that we're a few years away from really understanding if psychedelics have any potential to significantly impact a lot of different types of autoimmune conditions. Pretty speculative right now.
Yeah, I was thinking, I know that there's a trial for mild cognitive impairment, like depression and mild cognitive impairment. And I was like, It's almost perfect that there's been so much research on the depression, because then they have that sort of as an indication. And then it's like also looking sort of at the neuroplasticity and like the autoimmune, things that may be underlying, dementias and things like that. So it's like, you need to slowly segue so you can kind of get to different questions. But it's all very interesting. Back to maybe some more like basic pharmacology stuff. Do you suggest a washout period of medications, and how do you usually navigate that, or how would you usually suggest people navigate that with different other psychoactive medications or psychopharmacology?
It really depends on which psychotropics they're taking and which psychedelics that they want to use. If they're thinking of, I have PTSD, I really want to get to a clinical trial with MDMA-assisted therapy. Well, they're going to require you to stop your SSRI for that. And there's some pretty good data suggesting that SSRIs block the ability of MDMA to release serotonin. So it just kind of seems that from a lack of efficacy perspective, that would be a contraindication. If the person really wanted to go in that direction, that they would have to consider tapering and washing out that kind of medication. Whereas other circumstances, it's a lot less clear. Like I mentioned, psilocybin, for example, as some people report, it diminishes their antidepressant, like an SSRI, diminishes the effects of psilocybin. Some people report the effects are preserved and they get some pretty good therapeutic types of qualities out of psilocybin, even while taking an antidepressant. So a little bit of data has been emerging and coming out around this, and it's not very conclusive. It's very short term. They give healthy people SSRIs for a couple of weeks. And it's like, well, it takes 4 to 6 weeks for them to even work. So it's sort of like, how is this going to answer question overall, but at least in those short-term types of things, they have found that the effects of psilocybin, or at least the sort of positive or mystical effects, tend to be preserved. So this is essentially I think where, kind of cookie cutter psychedelic therapies, let's look at the chart and require everyone to stop their antidepressants to use psilocybin, may get us into a little bit of hot water, because some people get benefits from SSRIs. Some people don't really want to stop their SSRIs. Some people are very sensitive to withdrawal effects of SSRIs, and that could cause a type of clinical decompensation that puts them in a crisis before they're even able to get to that experience. Whereas some people haven't been taking them very long and either got side effects or didn't really get the benefits that they were hoping for, don't really feel attached to it overall, and are really looking for a different type of therapeutic alternative. And it makes a lot more sense for them to try and taper and discontinue than, someone that's, feeling really low at baseline and is predicted to feel a whole lot lower if you try and stop their medications. Maybe steer them towards something like ketamine. Can we get your depression a whole lot better with ketamine? It's compatible with your SSRI. And once you're feeling a whole lot better, we can revisit the question whether you really want to try and taper and try a different type of psychedelic or not. So depends on the med, depends on the question, depends on the person's life circumstances. Probably the best answer.
Yes, it's all very complex. So you talked about MDMA, ketamine, psilocybin, another psychedelic that you didn't touch on, but if you can comment on the use of ibogaine for addiction. I believe that it's been used for alcohol addiction. I'm not sure about that. Somebody mentioned opioids, and then another person had a general question about using psychedelics for opioid withdrawals.
Using psychedelics for opioid withdrawals, or specifically ibogaine?
Two questions. First one, somebody wanted to know about ibogaine and opioids treatment for addiction. Mm-hmm. And then the second one says psychedelics in general and for opioid withdrawals.
Yeah. Well, ibogaine is a psychedelic that is, it seems from all of the preclinical and the, very kind of limited amounts of observational data that's in the literature, that it is really potently anti-addictive. There's quite a bit of preclinical data out there talking about upregulated GDNF, or glial-derived neurotrophic factor, which seems to really dry up cravings for alcohol in a lot of people. Ibogaine's working on nicotinic receptors that are involved in things like smoking, but it probably primarily modulates opioid neurocircuitry and tends to have kind of a resetting effect to the opioid system. And ibogaine can detoxify people from short-acting and probably some of the more naturally occurring, like opiates, things like codeine, heroin, morphine, probably works a little bit better than some of the synthetic ones like fentanyl. And it's actually going to be contraindicated in people that are taking long-acting opioids like OxyContin, methadone, buprenorphine, because of this resetting effect and, essentially just a really dangerous situation where they could get into like respiratory depression. So ibogaine, really potently anti-addictive, not very much clinical research happening because it has real significant QTC prolongation to it and risks of things like ventricular arrhythmias, torsades de points, and just fatal types of cardiotoxicity. Bradyarrhythmias have occurred with ibogaine as well. And it's just an extremely long-acting type of psychedelic. It's between a 12 and 24-hour type of experience overall, and it's not notorious for pleasant effects, right? So I still think that we should be interested in developing it clinically, particularly for opioid use disorder or things like heroin use disorder, things like cocaine use disorder, where either stimulant use disorders, there's just no FDA-approved treatment options at baseline. And opioid use disorder, we're just in a public health crisis as far as opioid use goes. And we know that opioid use disorder is a really fatal type of disorder too, because of the kind of overdose risk. So to me, when I'm thinking about using a substance that has significant risks in of itself, like ibogaine with cardiotoxicity, there better be a real significant benefit or payout to be realized from that as well. And so perhaps for some more severe kind of addictions, the risk-benefit ratio is there, and with things like telemetry monitoring and crash carts available, that there is a path forward, but not much research happening with it, particularly in the U.S.
Yeah, I was going to say I'm really not as familiar with ibogaine, but sounds like there's a lot there. So you're right. It's always worth the investigation. On the similar line of addiction, can you comment on how psilocybin can help with smoking cessation?
Yeah, so I think that it kind of goes back to like there probably are some inherent types of neurochemical effects of the tryptamines like psilocybin that are anti-addictive, and particularly seems alcohol use disorder. There's many people either in clinical trials or either in anecdotal surveys that will kind of report that, God, I was just so sick of myself drinking all the time, and I ate a handful of mushrooms one evening, and I realized that I shouldn't do that anymore. And then they just reduced the amount, or they were able to stop drinking. So there may be some inherent anti-addictive effect, but I personally think that it's more, people give up addictions when they're ready for change. And this is just is they're selecting people in clinical trials that are motivated and ready for change. So I think that the psychedelic is wonderful in perhaps resolving ambivalence. Some days I want to stop, some days I'm not so sure, right? Or I know I want to stop, but I just don't really, I just feel like I need an intervention and some accountability and therapeutic support and structure and, some chemical help as far as drying up my cravings for cigarettes or alcohol. But I think that it's kind of, they have this, small clinical trial, right, of tobacco cessation and psilocybin. And I don't know the exact numbers. I mean, there's 12 participants, and, 7 or 8 or 12 of them have a pretty good outcome. Like they stop smoking after 6 months. And so you see it quoted everywhere that 75% of people that use psilocybin just stop smoking cigarettes. And I believe that, again, if you're picking people that are highly motivated and put them in the structured clinical program, and you might get those results. But anyone that's been to a music festival where a lot of people are ingesting mushrooms, there's a lot of people that are smoking cigarettes while eating mushrooms, right? So it's not quite as simple as, okay, mushrooms just stops the addiction, right? I think that there has to be some level of intrinsic motivation, and then I think the sort of therapeutic structure that is focused on addiction recovery that's paired with are probably the things that really make the differences. And I'm looking forward to like a much larger trial, right, with like a couple hundred people in it or something like that to like truly kind of understand it a bit more. It's a pilot study right now, I think.
Yeah, no, I agreed. I know which study you're referring to, and the results are interesting, but you're right. I mean, you really have to look at the rigor of the study, and they definitely need more research on that. So, to be determined. So somebody asked, when you refer to lithium as a contraindication to MDMA and psilocybin, does this apply to lithium carbonate only or orotate as well?
Oh, it probably is mostly lithium carbonate. So lithium orotate is like an over-the-counter supplement, and usually comes in 10 or 20 milligrams of lithium orotate, which to my calculation, like some counties have lithium in the drinking water in it. So a lithium orotate dose of lithium is probably somewhere between 3 and 5-fold what you find in like a county's like drinking water if it had in there. So the dose is pretty darn low overall. Whereas lithium carbonate is hundreds of milligrams. It's a different salt form. You're talking a couple orders of magnitude, like 100-fold, like increase over something like drinking water. Lithium has a half-life of about 24 hours. Okay, so even if you're taking lithium orotate, I haven't heard of people taking lithium orotate having withdrawal syndromes and things like that. So if you want to be on the safe side, you could hold your lithium orotate for 3 days, and most of it is going to be gone from your system, and you're not really going to have more in your system at that point than what would be in a cup of drinking water if it was in that county's water. So I tend to think of, okay, lithium orotate, no, that's probably not what they're talking about in these anecdotes where seizures occurred. It's probably more, 6 to 1,200 milligrams of something like lithium carbonate for a bipolar condition rather than a supplement that a person is taking.
So are there any studies looking at the combination of MDMA and cannabinoids?
Not that I'm aware of.
Along the lines of MDMA and other substances, if MDMA and psilocybin don't share a metabolic pathway, then why might MDMA potentiate the psilocybin experience?
Well, they don't share a metabolic pathway, but they share a pharmacodynamic pathway, in that both of them stimulate serotonin 2A receptors, and MDMA increases serotonin neurotransmission as well as dopamine and norepinephrine. So I think from the pharmacodynamic perspective of things, there's a lot of potential for synergy or overlap between the substances.
In particular with combining psychedelic substances, so somebody is giving the example of psilocybin, LSD, and MDMA. Any comments or observations sort of maybe elaborating on that in terms of like maybe therapeutic or research uses of combinations?
Yeah, I haven't seen any clinical trials that are planned as far as like combinations of these things. I'll say that in recreational settings or environments like music festivals, combining MDMA with LSD or MDMA with psilocybin is not uncommon at all. I haven't found much in the way of anecdotal literature that really supports that combining them increases the physical risk so much as far as, having cardiovascular events or things like that. But depending on the doses that you use and the timing of it, right? Like if you wait 4 hours after using the LSD to take the MDMA, then the LSD is already peaked. So, it's probably more like a continuation of that experience versus if you take them both at the same time right at the beginning and use high doses, you could get in places that are just way too psychologically intense and just not really what the person needs as far as their experience. So I'll say that for the moment, those combinations are kind of psychonautical, and there's not really much in the medical literature discussing either if that somehow improves the efficacy or if that somehow introduces safety risks.
Yeah, that makes sense. How about research on psychedelics for the treatment of ADHD?
Not a whole lot so far. ADHD is actually one that comes up quite a bit in surveys of microdosing. So not controlled research, right? But it's like surveys, like anecdotally, people will talk about because LSD stimulates serotonin 2A receptors and dopamine 2 receptors. So it tends to be a little bit more energetic and stimulating than some of the other types of psychedelics. And essentially the world of kind of like biohackers or like neurohackers are very interested in using low doses of LSD to like enhance cognitive faculties and things like that. So, but not much in the way of like controlled research, no. And there's different theories out there, right? Like the idea of like psychedelics may be helpful, really helpful, like psilocybin for like organizing types of conditions. So things that are more like, okay, a really rigid depressive rut, or the kind of rigidity of things like obsessive compulsive disorder. Maybe the sort of breakdown in the default mode network allows this kind of loosening of thoughts and beliefs that can be really helpful for those types of conditions, whereas ADHD is more of a disorganizing type of condition, and maybe they won't be that helpful there. But until you test it in a clinical trial, I don't really want to say that they wouldn't be helpful for that kind of condition, but I can't point to anything right now definitively and say like, oh yeah, there's that shows that there's really something going on.
Yeah. Maybe the last question, we're getting close to the end here. Somebody asked about, regarding ketamine, are there any studies on the epigenetics dosing?
Maybe, honestly, I'm not sure on that one as far as like quoting epigenetic studies with ketamine off the top of my head.
Somebody also specifically asked if there is a contraindication with pituitary tumor.
Well, I mean, they've essentially excluded all CNS tumors so far, right? So from that perspective, it's sort of like, okay, I don't know if they would be a candidate for a clinical trial. I had a talk with a neurologist recently that was planning a study in type of glial cell like brain cancer. It wasn't like a pituitary type of thing. I think it would sort of depend to me as far as like, well, how active is the pituitary tumor, and sort of like what are the sort of overall effects that it's like having on the body. Like one I don't even think I put on the exclusion criteria slide was like ectopic tumors, right? So if you have a tumor that is secreting epinephrine and the blood pressure is really through the roof and they have like a bunch of adrenaline pumping through their system all the time, it's like, well, maybe that wouldn't be a good idea to give them a psychedelic for that type of person. So I don't know if pituitary tumor necessarily just sounds like, oh, you should never do that, but maybe there's something, I'm not an oncologist, I'm a psychiatric pharmacist, maybe understanding more about the status of that cancer overall would be necessary.
Yeah, that makes sense. So for the last couple minutes, do you have any last comments that you want to make? Any take-home messages for our attendants?
Well, I think again, thank you to UPenn Nursing for putting on this event series, and thank you so much for the opportunity to speak. And I really have enjoyed like a lot of these questions that we've gone through as well. And it may be early days for a lot of these things that we're talking about as far as neurological conditions, autoimmune conditions, microdosing for all of these conditions. But it really seems like there's enough out there definitely with ketamine and with MDMA and psilocybin, and probably things like ayahuasca and ibogaine and short-acting inhaled tryptamines. We didn't even touch on those, like 5-MeO, DMT, or NN DMT, that are essentially all being studied intensely at this point in time. And, you are free to take this information and make up your mind about it, whether you think it's a good thing or whether it's a bad thing. I'm not really here to try to convince you one way or another. I just think that many people for a long time have been very close-minded to the idea of non-ordinary states really being able to have any type of benefit associated with it. And there's a huge stigma there. There's a huge stigma around the use of an illicit substance or an illicit drug. There's a huge stigma with mental health conditions in general. So this whole thing is really an area that I would encourage the skeptics to kind of suspend some of their judgment, and when they start getting questions from their patients about it, right? Because your patients are probably going to start asking questions to have an articulate response, and maybe some places to point them to as far as resources or help, because most of them, if not all of them, are really like Abigail. where they're suffering, they want to get better, and they are reading headlines in the New York Times. They're reading best-selling novels about this kind of stuff and coming to the table serious about doing the sort of therapeutic work that comes alongside them. And I don't know, I just sincerely believe that humanity deserves these opportunities. And I'm so looking forward to the days that I can update my slides and just have these be legal substances, and we can kind of get rid of the disclaimers that say we're talking about illicit and experimental compounds. And I think it's quite near.
Yeah, I mean, I couldn't agree more. I definitely think, like, as this conversation has gone on, we've realized it is complicated and there's so much science that needs to be done, but I'm glad that, people are opening up about it, because it's all very fascinating and it could really have, a great impact on people. So we're lucky to have you here, who's an expert and who is actually able to answer some of these questions. So I thank you very, very much for your presentation and for hanging out with us and answering these questions. So that's going to wrap up our Q&A session. Big thank you for joining us tonight. Definitely, I know this was a super informative and really, really interesting experience for all of our attendees. Just another logistical thing, to all the attendees, you're going to be receiving an email that will include the recording of tonight's session, some resources that Dr. Malcolm will recommend for us, and then information about nursing continuing education credits, and of course a feedback survey. And we really encourage you to share your feedback. We're really striving to improve this series, especially as we consider future psychedelic learning opportunities. The next session of the series will be the current landscape of psychedelic medicines, and that will be on Wednesday, March 2nd at the same time from 6:30 to 8 p.m. Just a reminder, you do need to register for each session individually, and we encourage you to register no matter what, even if you can't make it, because then you'll just get the recording and you can watch it another time when you're free. So thanks so much to everybody. See you next time.